Good morning, my dear teachers and colleagues. Today we are going to discuss about intraductal papillary mucinous neoplasm of pancreas. So uh, there's there is a WHO classification of the pancreatic neoplasms, among which the cystic neoplasms can be either benign, borderline, or malignant. And intraductal neoplasms are such kind of cystic neoplasms of pancreas. These tumors are of ductal origin, and they are characterized by intraductal polypoidal papillary nodules and often associated with cystic dilatation of the ducts. And these lesions are considered to be the precursors to invasive carcinoma, that is the pre-invasive neoplasms. Just like there is a pan-in, that is the pancreatic in situ carcinoma, which is a precursor lesion for pancreatic adenocarcinoma. The intraductal neoplasms are also the pre-invasive neoplasms for pancreatic carcinoma, adenocarcinoma. Then what is the difference between the pan-in and the intraductal neoplasms? The intraductal neoplasms are clinically detectable masses, most often more than 1 centimeter, unlike the pan-in, which are more often a microscopic diagnosis. And uh, hence the term tumoral intraepithelial neoplasia is also being used for these intraductal neoplasms. And 15% of the invasive adenocarcinomas are known to be arising from these intraductal neoplasms. And there are two main types of intraductal neoplasms. One is intraductal papillary mucinous neoplasms, and the other one is intraductal tubulopapillary neoplasms. The main difference of tubulopapillary from that of papillary mucinous neoplasms is the absence or very minimal mucin secretion and the characteristic tubular architecture on microscopic examination. So, to summarize, the intraductal neoplasms are of ductal origin and they are characterized by polypoidal papillary nodules with ductal dilatation, and they are different from pan-in in that they are they form clinically detectable masses. And this is the WHO classification of the pancreatic neoplasms, and we can see here that the intraductal neoplasms have been grouped under benign as well as precursor lesions. And again, each intraductal papillary lesion, either papillary lesion or a tubulopapillary lesion, or also there is another variant called oncocytic papillary neoplasm. All these, they are again differentiated based on the degree of dysplasia, either low grade or high grade. And also these lesions can also be associated with invasive carcinoma. Earlier in previous WHO classification, there is a three-tier system of grading, which is uh, now changed to a two-tier system, that is low grade and high grade alone. Coming to the intraductal papillary mucinous neoplasms proper, these constitute around 70% of all pancreatic cystic neoplasms. Predominantly, they are situated in the head region, and most often they are noted in the elderly men. The mean age of incidence is around fifth to seventh decade. And the characteristic finding or the characteristic of this endoscopic finding of this particular lesion is the mucus discharge, copious mucus discharge from the ampulla of Vater. The ampulla appears bulged, and also there is a significant discharge which gives it a characteristic fish mouth appearance. And such an endoscopic appearance is a diagnostic of IPMN. And also on imaging, either CT or MRCP, which shows the characteristic ductal dilatation with irregularities. But to differentiate it from other inflammatory stricture causing dilatation, there won't be no stricturing or narrowing of the duct in case of IPMN, unlike in any chronic pancreatitis. And also the chronic pancreatitis is associated with calcifications, unlike the IPMN. And there is a typical adenoma to carcinoma progression in case of IPMN, which is seen in like in colonic polyps. So hence, few others have correlated or made an analogy of this intraductal papillary mucinous neoplasms with that of the colonic polyps. And again, as I already told, there are based on degree of atypia, this can be a low grade or a high grade. And also these neoplasms per se can give rise to adenocarcinoma, or they can also be associated with adenocarcinoma in rest of the pancreatic gland. And invasive carcinomas that are arising in IPMN are graded and stays like that of other adenocarcinomas in the pancreas. Coming to the pathological features of IPMN, they can be diffuse or segmental dilatation of the pancreatic duct without stricturing, as already mentioned, and intraductal expansion of mucin producing ductal cells. So these mucin producing ductal cells will form either a papillary projection or a flat expansion within the duct, and there is a copious production of the mucin by these cells. And also the dilatation of either one or both the pancreatic orifices, that is the opening of the into the ampulla of Vater, opening of the ampulla of, at the ampulla of Vater is also noted, dilatation of the opening. And Ohashi has described a classical triad on ERCP finding to diagnose with the intraductal papillary mucinous neoplasm, which is consists of one, the bulging of the ampulla of Vater and the copious production of mucus through the bulged ampulla, and the third one is the dilated pancreatic duct, main pancreatic duct. Coming to the differences between pancreatic intraepithelial neoplasia and IPMN, as I already told, both are considered to be the pre-invasive lesion or pre-malignant lesions of the pancreatic adenocarcinoma. But as already mentioned, PAN or pancreatic intraepithelial neoplasia is not clinically detectable. It is more a microscopic diagnosis or pathological diagnosis, whereas IPMN forms a characteristic clinically visible lesions. And there is no mucus production or mucus ooze from the ampulla in case of PANIN, but it is typical of IPMN. And the duct size is also another distinguishing feature between the IPMN and PANIN. The duct size is usually enlarged in case of IPMN, which is more than 5 mm, and more often it is more than 1 centimeter. And intraluminal mucin production is again associated with IPMN, but not with PANIN. And growth patterns, PANIN has a typical flat type of growth pattern, whereas IPMN has typically a papillary type of growth pattern, and flat type is very rare. And the papillae that are seen in case of PANIN are microscopic, whereas the IPMN, it is a macroscopic or grossly visible papillae which forms nodules. And when it comes to associated adenocarcinoma, PANIN will give rise to only typical or conventional adenocarcinoma, whereas IPMN, that type of carcinoma depends on the pathological variant of the IPMN. We see what are the various pathological variants and what are the various anatomical variants of IPMN. Coming to the classification of IPMN, as I already told, there are two kinds of classifications. One is the anatomical classification based on the site of disease, and the other one is a pathological classification based on the histomorphological features. Coming to anatomical classification, it is mainly three types. One is main duct when the involves the main pancreatic duct, it is called as main duct IPMN. If it involves the branch ducts alone, it is called as branch duct IPMN. If it involves both branch duct as well as main duct IPMN, it is called as mixed type. Main duct IPMN, as already told, involves main pancreatic duct diffusely or segmentally, and majority arise within the head of the pancreas, and that progress distally. And main duct IPMNs are more aggressive than branch duct IPMNs and are more likely to harbor a malignancy. And at 10 years, the risk of 10 years after diagnosis, there is a 70% risk of developing a malignancy. Coming to branch duct IPMN, it occurs in younger patients and arises in uncinate process or rarely in the tail of the pancreas. And these branch duct IPMN have a lower risk of malignant transformation compared to the main duct IPMN, which is around 20% at 10 years after the diagnosis. Coming to mixed type of IPMN, it will behave in between the main duct and branch duct in terms of aggressiveness, but rest of the clinical features or other parameters are all same like that of the main duct IPMN. Coming to histological classification, there are four histological types. One is intestinal, the other one is gastric, then pancreatobiliary, and the fourth and most recent one is oncocytic type. Coming to intestinal type, it is the most common subtype of main duct IPMN, and as I already mentioned in main duct IPMN, that these lesions typically occurs in the pancreatic head, more common in the pancreatic head region, and may involve the entire duct. And the growth pattern in intestinal type is villous, resembling the villi of the intestine. And it expresses the mucin 2, mucin 5, and CDX2 markers, which are also expressed in colonic intestinal mucosa. And the invasive carcinoma that is associated with this intestinal type of IPMN is mucinous type or colloid carcinoma, which is also resembles the mucinous carcinoma of the colon. And usually 30 to 50% risk of malignancy is noted in intestinal type of IPMN. The other variant is pancreatobiliary variant. It typically involves the main duct in the pancreatic head and produces less mucus than intestinal type. And it consists of complex arborizing type of papillae, and the cells resemble that of the pancreatic and biliary duct cells and express mucin 1 and mucin 5. And the invasive carcinoma that is associated with pancreatobiliary is a conventional ductal adenocarcinoma, otherwise called as tubular adenocarcinoma. And these malignancies are more aggressive than compared to the colloid carcinoma or mucous carcinoma that is associated with intestinal type. And the risk of malignancy is also more with pancreatobiliary compared to the intestinal type. In intestinal type, the risk of malignancy is 30 to 50%, but in pancreatobiliary, it is more than 50%, often around 60 to 70%. Coming to oncocytic type, it is the least common and very rare variant, which has been recently separated into a separate entity and often forms large tissue nodules, which are most often more than 3 centimeters in size in the main pancreatic duct, and also it produces very little mucus. And as already mentioned, like in pancreatobiliary type, the oncocytic type also forms complex papillae, but the main microscopic difference between the two histological variants is the eosinophilic cytoplasm of the cells. And the expression of the mucin 1, mucin 2, and mucin 5 are also very inconsistent in case of oncocytic type, and also the expression is very focal. The fourth type is the gastric type, which is usually seen or associated with the branch duct IPMN, and it's the most common subtype overall. Though intestine is most common in case of main duct IPMN, overall it is the gastric type that is more common, and it is typically found in the periphery of the pancreatic parenchyma, often in the unstretched process. And the cells here resemble that of the gastric foveolar cells and form pyloric gland-like structures at the base of the papillae. And also they consistently express mucin 5 and mucin 6, and do not express or rarely only focally expresses mucin 1 or mucin 2. This is how it can be differentiated from intestinal type. And the invasive malignancy that is associated with uh, gastric type of IPMN is again conventional ductal or tubular adenocarcinoma, and the risk of malignancy is 10 to 30%. Coming to the prognostic relevance of these morphological types of intraductal papillary mucinous neoplasms, as I already mentioned, there are four variants, and size was significantly larger in case of intestinal type compared to the gastric type. And the pancreatobiliary on oncocytic types typically produce the mural nodules, which are seen in 93% and 100% of the cases respectively. The gastric type IPMN is typically associated with a low-grade dysplasia, and the chances of progression to malignancy are also relatively less, as we already seen. And the invasive oncocytic carcinomas are exclusively associated with the oncocytic type of IPMNs. And the pancreatobiliary IPMN is associated with the tubular type of adenocarcinoma, and the intestinal type is associated with the mucinous or colloid type of carcinomas. And the papillary nodules of intestinal type IPMN are morphologically identical to colonic villus adenomas. As I already told, there is an analogy that has been described by various authors. And they express the intestinal type lesions express mucin 2 and CDX2, which is also a common feature that is expressed in case of neoplasms of the colonic mucosa. Among all the histological subtypes, the worst prognosis is seen with pancreatobiliary type of IPMN. In this particular study, they also looked into the survival data regarding the type of anatomical classification, and they note that the main duct IPMN has a poorer survival among all the three, with a 5-year survival of 83.2 and a 10-year survival of 66.8. Whereas the branch duct IPMN has very good survival with a 5-year survival of 94.7 and a 10-year survival of 90. Coming to the clinical features of the IPMN, majority are asymptomatic and are incidentally detected, and non-specific symptoms like nausea, vomiting, abdominal pain, or back pain, or weight loss, or anorexia might be there. And as already mentioned, most are usually detected for the because of the endoscopy or imaging done for some other indication. Pancreatitis-like symptoms can be seen in some patients with exocrine and endocrine insufficiency, and most of the times the routine lab investigations are all normal. And the tumor markers like CA99 and CA are also normal unless there is an invasive component. Only less than 20% of the cases of non-invasive IPMN will have an elevated CA99 or CEA. These are typical radiological and endoscopic pictures of a IPMN. Here we can see a bulged papilla with a mucus discharging from the papilla, which is typically described as a fish mouth appearance. And here, this is the picture of a main duct IPMN. We can see only the main duct is dilated, and here it is the main duct is not dilated, but there is a branch cystic dilatation of the branch duct which is communicating with that of the main duct. So this is how the cystic neoplasm of other kind like the mucinous or serous can be differentiated from that of the branch duct IPMN, because the branch duct IPMN will have communication to with that of the main duct, but sometimes the communication may not be readily appreciable, may not be easily appreciable. And this is a mixed type IPMN where you can see a dilatation of the main duct as well as there is a branch duct dilatation which is communicating with the main duct. Coming to the management, so the main or important treatment or the management of the IPMN lies in identification or recognizing those individuals who are at high risk of turning into invasive type or who are having a synchronous invasive component. So there are certain guidelines that are proposed by various societies to identify these individuals and also to plan accordingly the treatment protocol or the surveillance protocol. Uh, the main societies are, one is the European Study Group guidelines, the other one is American College of Gastroenterology guidelines, then American Gastroenterology Association guidelines, then American College of Radiology guidelines, and International Association of Pancreatology guidelines. Among these, European Study Group guidelines and American Gastroenterology Association guidelines and International Association of Pancreatology (IAP) guidelines are more important or more clear. And the almost all of these guidelines differ either in the method of formulation or target population. That is, some guidelines include all pancreatic cysts, or some guidelines include only mucinous cysts, and some guidelines, or only one guideline that is more specific for IPMN is IAP guidelines. And also the variables that are considered as a criteria to identify the high risk individuals or high risk features are different among the different guidelines, and also the timeline of surveillance recommended is also different among various guidelines. Because of this heterogeneity, no single guidelines can be mentioned as superior to over the other, and it all depends on which clinical population you are assessing, and uh, also the surveillance protocol that you would follow. Coming to the AJA guidelines, that is American Gastroenterological Association guidelines, the target population in this particular guidelines is asymptomatic pancreatic cystic neoplasm patients. That means it include all the pancreatic cystic neoplasm cases, but the patient should be asymptomatic. And specifically, this particular guidelines did not consider either solid papillary neoplasms or cystic degeneration of an adenocarcinoma or cystic neuroendocrine tumors, and also this particular guidelines did not include main duct IPMN without the branch involvement, which is a major drawback of these guidelines. And the method of formulation is, again, it's formed by the American Gastroenterological Clinical Practice Guideline Committee, and they have framed 7 questions which are based on which are on the lines of PICO pattern, and they have given a grading of evidence, grading for the evidence to answer, that is they have analyzed to answer these 7 questions. And the questions were addressing initial, what should be the initial imaging evaluation of the cyst, and what is the surveillance protocol for this cyst, and what should be the surgery, and also what should be the surveillance after the surgery, and when to discontinue the surveillance. So the guidelines says that the patients with pancreatic cysts less than 3 centimeters without a solid component or a dilated pancreatic duct can undergo MRI surveillance in 1 year, and then every 2 years for a total of 5 years. And after the 5 years, if still there is no change in the characteristics of the duct or of the cyst, then this is the only guidelines which says that the surveillance can be stopped after 5 years. And in case of pancreatic cysts with at least 2 high risk features, that is one size more than or equal to 3 centimeters, or a dilated main pancreatic duct, or presence of an associated solid component, among these three, presence of any 2 high risk features, then these particular guidelines recommends to perform an US guided FNA. Patients without concerning US FNA results, that is either no positive cytology or no elevated CEA in the aspirate cyst fluid. Uh, they should undergo MRI surveillance after 1 year and then every 2 years to ensure that there is no change in the risk of malignancy. And significant changes in the characteristic of the cyst, including the development of a solid component or increasing the size of the duct or increasing the diameter of the cyst up to more than 3 centimeters, are indications for US guided FNA. And these particular guidelines suggest against continued surveillance of pancreatitis if there has been no significant change, as already mentioned, after the 5 years of surveillance, or if the patient is no longer a surgical candidate. And patients with both a solid component and a dilated pancreatic duct or a concerning feature on US and FNA should undergo surgery to reduce the risk of mortality from carcinoma. Again, this is the only guideline which has suggested against the surveillance after the 5 years if there are no high risk features. And this guideline also suggests against the routine surveillance of pancreatitis without high grade dysplasia or malignancy after surgical resection. So these guidelines only recommends post resection surveillance for individuals who are having either high grade dysplasia or malignancy. Rest of the guidelines suggest post resection surveillance even if the uh, resection specimen shows only low grade dysplasia. Coming to the next guidelines, it is the IAP guidelines, and the target population here is very specific. That is the suspected IPMN. No other guidelines has taken a target population of IPMN alone. And the method of formulation, these guidelines were found by expert multidisciplinary panel. The initial guidelines were proposed were in 2006. That is the Sendai guidelines. Later, 2012, they are modified and Fukuoka guidelines have been released, and then the Fukuoka guidelines have been again revised in 2017. And the most latest is the revised Fukuoka guidelines that have been released in 2017. According to the recent 2000 revised Fukuoka guidelines, the criteria for distinction of branch duct IPMN and main duct IPMN are on the main duct IPMN will have a segment or diffuse dilatation of main duct of more than 5 mm without other causes of obstruction. And the main duct dilatation of 5 to 9 mm is not an immediate surgical indication according to these guidelines, but can be considered as a worrisome feature, while a main duct diameter of more than or equal to 10 millimeter is a high risk stigmata which indicates the surgical resection. And coming to branch duct IPMN, the pancreatic cyst of more
Srinivas,
than
can you
more
speak closer to mic?
madam
Now it's okay. Better. Speak closer to the mic.
pancreatic cysts of more than 5 mm in diameter that communicate with the main pancreatic duct are considered as a branch duct IPMN. And mixed type are those that meet the criteria for both main duct as well as the branch duct IPMN. So, according to this criteria, duct size of more than or equal to 10 centimeters, main duct size of more than or equal to 10 millimeters is a high risk stigmata that needs surgical resection, and diameter between 5 to 9 mm is not an immediate indication, but is a worrisome feature that needs further evaluation. And duct diameter of more than 5 mm is considered as a diagnostic of main duct IPMN, provided there is no other cause of obstruction. And branch duct IPMN is considered when there is a dilatation of branch duct of more than 5 mm or presence of cysts of more than 5 mm, which communicate with the main duct. And according to these guidelines, the definition of malignant IPMN, they looked into various definitions and they finally came to a conclusion that there is no single definition that can be applicable to define malignant IPMN. And they noticed that some of the others has included both carcinoma in situ and also the invasive carcinoma together, but some others included only the invasive component, while some others only described the highly aggressive variants as a malignant. So they suggested that to abandon the term carcinoma in situ and more to use a high grade dysplasia as outlined in the WHO classification, and also they suggested to avoid using the term malignancy rather than using the term invasive papillary mucinous carcinoma, or use the word only invasive neoplasm. Coming to the other components of these guidelines, they have proposed the guidelines for workup of cystic lesions of the pancreas, and they said that any cyst that is less than 5 millimeters in an asymptomatic patient needs no further workup, only follow-up is sufficient. But if the cyst is more than 5 in size, then a pancreatic protocol CT or a gadolinium enhanced MRI with MRCP is recommended. And among the two, the guidelines say that MRCP is more preferred because it has a superior contrast resolution that facilitates recognition of the septae, nodules, and also the ductal communication. And also the exposure to radiation is less. And the symptomatic cyst, irrespective of the size, needs to be evaluated further. And if depending on the clinical circumstances, if the patient is symptomatic and the symptoms needs to be ameliorated, then straight away one can go for surgery. And if there is no such clinical indication for surgery, then after further evaluation, the call can be taken. Coming to distinction of branch duct IPMN from other pancreatic cysts, MRCP or CECT usually shows a multiplicity and visualization of a connection to the main pancreatic duct. As already told, there can be other cystic lesions in the pancreas, but the communication to the main duct is what differentiates between branch duct IPMN from that of the other pancreatic cysts. Then coming to the role of endoscopic ultrasound, the mural nodules and the invasion is better delineated by using the endoscopic ultrasound, and the vascular supply can be better assessed. The vascular supply of the mural nodules can be better assessed using the endoscopic ultrasound. And also EUS can be used to obtain the cyst fluid for analysis like CEA and MLS levels. And also cytology of the cyst fluid can be done. But one important drawback from this of these analysis is that the USFNA will not distinguish between MCN, that is a mucinous cystic neoplasm, and IPMN. It only can differentiate between serous type and the mucinous type, and also it can differentiate between other types of cysts, but not between the mucinous cystic neoplasm and IPMN. And molecular analysis of the molecular analysis for GNAS mutations is only one thing that can differentiate between a IPMN and a MCN, that is mucinous cystic neoplasm, where the positive mutation is observed only in IPMN but not in mucinous cystic neoplasm. So this is the treatment algorithm proposed by the IAP Society, IAP Guidelines Association, and this is the algorithm for management of the branch duct IPMN. So the main duct IPMN, irrespective of the features, it has to be treated. That is, the surgery is the treatment. But the branch duct IPMN, the treatment varies based on the various variables. So if any of the high risk stigmata are present, that is, one is obstructive jaundice in a patient with a cystic lesion of the head of the pancreas, or an enhancing mural nodule of more than 5 or dilatation of the main pancreatic duct to more than 10 is an absolute indication for surgery. And so the patient can straight away be taken up for surgery. If none of these high risk stigmata are present, then to look for the worrisome features or clinical symptoms. If the patient is having clinical symptoms, uh, then again, like pancreatitis, then it is also again an indication to evaluate further, especially the endoscopic ultrasound. And other worrisome features, apart from clinical features, the worrisome features on imaging are: one, cyst size of more than or equal to 3 centimeters, an enhancing mural nodule which is less than 5 or a thickened or enhancing cyst wall, or a main duct size of 5 to 9 or an abrupt change in the caliber of the duct with a distal pancreatic atrophy, or a lymphadenopathy, or an increased serum level of CA99 of more than 37, or cyst growth rate of more than 5 over 2 year span. So all these are considered as worrisome features because all these are shown to be associated with increased risk of invasive component on various studies. If any of these worrisome features are present, then especially if there is a definitive mural nodule of more than 5 or main duct features are suspicious of for involvement, or if the after performing the US, if after performing the US, if any of the following three features are present, then again it is an indication for the surgery. These are considered as a concerning features on the endoscopic ultrasound. That is, one is the presence of definitive mural nodule of more than 5 or main duct features suspicious of involvement. So what are these main duct features that are suspicious of involvement? Is one is a presence of a nodule within the main duct, tumor nodule, and this tumor nodule has to be differentiated from the mucin block or mucin glob. So how can we differentiate this? One is uh, the mobility of the mucin plug is will be there, but the nodule will not move with the change of the position. The other one is the presence of the flow, blood flow on Doppler imaging, and the other one, the other direct evidence is the FNA from the nodule itself, which can be either suspicious or positive for malignancy. So if any of these features are present, then again it is an indication for the surgery. Then if none of these features or concerning features are present on endoscopic ultrasound, then to consider the size of the cyst, size of the largest cyst. If the size of the largest cyst is less than 1 centimeter, then a surveillance of at 6 months is done using either CT or an MRCP, and then it is repeated at every 2 years if there is no significant change or there are no worrisome features. If the size of the largest is between 1 to 2 centimeters, then again CT or MRI is surveillance CT or MRI MRCP is done at 6 months for at 6 month interval for 1 year, then yearly for 2 years, and then the interval is for further interval depends on the changes. If there is no further change, the interval can be continued at 2 year interval. If the size is between 2 to 3 centimeters, then EUS is recommended at 3 to 6 months interval, then lengthening the interval up to 1 year, alternating with MRI. And if the patient is young and fits for surgery and also needs a prolonged surveillance, then surgery can be considered if the size is between 2 to 3 centimeters. And if the size is more than 3 centimeters, definitely a strong recommendation is in young patients is to go for surgery. But in elderly patients, it is that is more than 65 years, it is prudent to go for only surveillance because of the associated morbidity of the procedure. And the close in the surveillance in case of more than 3 centimeter size is a close surveillance with an interval of 3 to 6 months. So to summarize, look for the high risk stigmata. If present, go for surgery. If there are no high risk stigmata, then look for worrisome features. If there are worrisome features, then it is prudent to perform an endoscopic ultrasound. And if there are concerning features on endoscopic ultrasound, then again go for surgery. But if there are no concerning features on endoscopic ultrasound, look for the size of the cyst, and uh, the surveillance protocol will be decided based on the size of the cyst. And especially in younger patients with a cyst of larger than 2 centimeters, surgery can be considered. So coming to the other aspects of these guidelines, coming to surgical aspects, the pancreatiodynectomy or a left or total pancreatectomy can be done according to the site of the disease. If the disease is limited to the right side, then pancreatiodynectomy. If it is limited to the left side, then left. Or if it is involving the entire duct, entire pancreatic duct, then a total pancreatectomy may be considered. And almost always it is prudent to do a lymph node dissection because we can never know whether there is an invasive component associated with the IPMN unless the histological specimen is completely evaluated. And in segmental ectatic type or a diffuse type with focal lesions, as already mentioned, where there will be a focal lesion at one side, it is relatively easy to determine the plane of resection. And limited resections or even focal anatomic non-anatomic resections like excision, enucleation, or uncinectomy have been tried for branch duct IPMN, which are focal without any signs clinically or radiologically or cytopathologically or serologically of suspicious of invasive carcinoma. But the problem with these limited resections or non-anatomical resections is the high risk of mucin spillage, which can later on lead to pseudomyxoma peritoniae, and also the chances of residual disease or recurrence, and also uh, there is a chance for high chance of pancreatic fistula development. So considering all this, the limited resection are very rarely performed, and also the indications are very rare. Coming to the role, and these guidelines was also looked into the role of frozen section biopsy and its usefulness regarding the surgery of IPMN. And they found that frozen section is useful and recommended to determine the extent of resection. If the resection margin is positive for invasive cancer or high-grade dysplasia, then additional resection of the pancreas should be attempted to obtain a negative margin. But if the resection margin is positive for only low-grade dysplasia, then further resection is not necessary. Coming to the surveillance, according to these guidelines, surveillance should continue as long as the patient remains fit for the further resections. This is the post-surgical surveillance. And the cross-sectional imaging at least is recommended at least twice a year in the initial first year, and especially in those with a high risk for family history of pancreatic ductal adenocarcinoma, or a margin positive surgical resection for high grade dysplasia, or a non-intestinal subtype of resected IPMN. In these individuals, at least twice a year, the cross-sectional imaging is recommended at least for first 1 to 2 years. Then every in all other cases, other IP types of IPMN, cross-sectional imaging can be done every 6 to 12 months. Preferably, at annual imaging is sufficient after first year. Then follow-up strategy of invasive IPMN should be the same as that of the pancreatic ductal adenocarcinoma. So this surveillance protocol is almost in line with that of the other guideline surveillance protocols, except that of the American Gastroenterological Association guidelines, which says that if there are no significant changes or worrisome features, the surveillance can be stopped after 5 years. And also, they suggest that there is no surveillance is needed for low grade IPMN, but here in IAP guidelines, respect of the hello, am I audible?
Audible. Continue, continue, you're audible.
Coming to other guidelines, it is the European guidelines. So the target population here is all pancreatic cystic neoplasms. It included both symptomatic as well as asymptomatic, and the method of formulation is again by an expert panel representing different European associations. And the guidelines are used to differentiate the pancreatic cyst risk and the surveillance based on the type of the cyst as defined by the WHO criteria. And one important drawback or important drawback of these guidelines is that they do not offer specific upfront criteria to distinguish between various cystic lesions of the pancreas. They only give the guidelines after the uh, diagnosis or confirmation of which type of cystic lesion it is. So they didn't give guidelines to identify how to identify which type of cystic lesion it is. According to the guidelines, jaundice or the presence of an enhancing mural nodule of more than 5 mm or a solid component on a positive cytology or a main pancreatic duct of more than 10 mm is considered as a high risk feature and is an indication for surgery in a fit patient. If the main pancreatic duct dilatation is between 5 to 9.9 mm, or the cystic growth rate is more than 5 mm per year, or the CA99 value is more than 37, or the patient is symptomatic, or enhancing mural nodules of less than 5 mm are present, or a cyst diameter of more than 4 centimeters, these are all considered as worrisome features that is associated with an increased risk of high grade dysplasia or malignancy. So this needs further evaluation. This is the only guideline which has considered a cyst diameter of 4 centimeters, while rest of all the guidelines has considered a cutoff of 3 centimeters. So again, the same, the guidelines has considered absolute indications and relative indications. So the absolute indications are, one is the, as I mentioned, positive cytology for malignancy or high grade dysplasia, solid mass or a jaundiced patient, which is caused by a tumor or a cyst in the head of the pancreas. Then an enhancing mural nodule of more than 5 mm in size, or a main pancreatic duct dilatation of more than or equal to 1 centimeter. And the relative indications, as already mentioned, growth rate of more than or equal to 5 millimeters per year, and increase the levels of serum CA99, or a main duct size between 5 to 9.9 mm, or cyst diameter of more than 4 centimeters. And also this included the symptoms, that is, one is new onset of diabetes mellitus or acute pancreatitis caused by IPMN, and also enhancing mural nodule of less than 5 mm. All these are relative indications for surgery. So for patients with an IPMN without an indication for operative intervention, routine follow-up is recommended, and the follow-up interval is a 6 month in the first year and yearly thereafter, when no other risk factors are present for surgery. And so whenever there is a change in the clinical symptom, or when there is a change in the characteristics on imaging of the lesion, then it should indicate further investigations even during the surveillance. And for patients with any relative indication, look at one should consider the age and the comorbid status of the patient. In case of elderly and those with a severe comorbidity, a 6 month follow-up is recommended rather than surgery. This is the protocol that is proposed by the European guidelines. So if there is no if there is an absolute indication for surgery, go for straight away surgery. And for post resection, there should be a lifelong follow up. So especially in those who have undergone partial pancreatectomy, and those patients who are unfit for surgery, no further follow up is required. And those who don't have any indication for surgery, either relative or absolute, no indication is there, then they can go for regular surveillance. One is first year from diagnosis, that there should be clinical evaluation, and serum CA99 should be measured, and either an MRI or an endoscopic ultrasound can be used. Again, this is the only guidelines which is using CA99 during the surveillance. And after the first year from diagnosis, again, yearly is enough, but during the first year, 6 months surveillance is needed. The most controversial thing is regarding the relative indications for surgery. So if the patient with relative indication has a relative indication for surgery, then consider the comorbid status as well as the life expectancy or the age of the patient. And in those individuals with one relative indication and elderly or comorbid status can be kept under surveillance. But those without any significant comorbidity or young individuals, even with a single relative indication, can be considered for surgery. And in any individual with two or more relative indications, can be straight away considered for surgery. Coming to the surgery, an oncological resection including standard lymphadenectomy is the preferred procedure for IPMN with absolute indication for resection. Absolute indications for resection, and the surgical approach for most branched IPMN is again an oncological resection with a lymphadenectomy. The parenchymal sparing resections, which I already mentioned previously, that non-anatomical resections or uh, local excisions, which is suitable only for a uh, very rare lesions with a very low probability of malignancy. For example, single cystic lesion of a branch duct like that. And also regarding the surveillance, they say that the surveillance should be followed until the patient is no longer fit for surgery, and lifelong surveillance is recommended following the resection if the patient is fit. And the patients with an evidence of IPMN associated with invasive carcinoma, the follow-up is similar to that of a adenocarcinoma. Coming to IPMN with high-grade dysplasia or moderately differentiated IPMN should have a follow-up of main duct IPMN should have close follow-up of every 6 months, as already mentioned, for first 2 years, then followed by yearly surveillance. And in case of low-grade dysplasia, follow-up can be similar to similar to that of non-resected branch duct IPMN. And according to these guidelines, MRI is preferred over the EUS. And again, this guidelines also recommends frozen section. And frozen section, if there is a high-grade dysplasia or a malignant invasive component, then resection is needed. If there is no, if it is only a low-grade dysplasia, then there is no need of further resection. So this is a comparison of various guidelines. You can see the variables among different guidelines are different. Coming to the European guidelines, as I already told, this is the only guideline which included CA99. And uh, coming to the difference in the various patient targets, European guidelines are the most generalized guidelines, which is applicable to all patients with cystic neoplasms, which are both symptomatic as well as symptomatic. Whereas American Gastroenterological Association guidelines are only all types of cysts, but only asymptomatic patients. But and also they included some high risk entities like main duct IPMN without branch duct involvement. The Fukuoka guidelines are the most specific, which target only the IPMN. Thank you. And this is a various surveillance protocols which I already discussed based on the size of the cyst. And these are the various studies that have looked into various guidelines, how they perform. And almost all of the studies has mentioned that the AGA guidelines, the American Gastroenterological Guidelines, and the Fukuoka guidelines have a higher diagnostic accuracy compared to either ACR or Sendai guidelines or other guidelines. So, to conclude, there is an overlap among all the guidelines, but they differ mainly based on the target population and also the variables they have selected. But when it comes to accuracy, almost all the guidelines have similar accuracy. But in a multi-center study performing assessing the performance of American Gastroenterological Association and Fukuoka guidelines, they noticed that the Fukuoka guidelines likely will lead to a greater number of benign resections but missed fewer cancers. So they lead to more resections than the AGA guidelines, but they picked more number of cancers compared to the AGA guidelines. Please complete. Risk of malignancy in IPMN in case of branch duct, it is around 10 to 20%, sir. In case of main duct, it is around 30 to 50%. If the imaging is characteristic of IPMN, then the role of endoscopic ultrasound guided FNA is almost nothing. Yes, sir. That is the only gray area where US has a role where you can go for US guided cytology as well as the cyst fluid analysis for amylase as well as CES. Cytogenetic only genus mutation is helpful to differentiate between the mucinous cystic neoplasm and IPMN, whereas without cytogenetic, we can differentiate between the mucinous and non-mucinous type of neoplasms. With the KRAS mutation is also most commonly associated with mucinous types, but it is present in both IPMN as well as mucinous cystic neoplasm. Sir, what is the no?
We can't hear the questions. What's going on?
What is the question, sir? Kindly.
Am I audible now? Hello, am I audible? Where is
Yeah.
Rexina?
Yes, sir.
So my question was when you get a patient who is of carrying good, moderate to high risk of surgical procedures in terms of poor GC and all, is there a role in further evaluating by using endoscopic ultrasound and cyst fluid aspiration and looking for various markers to diagnose malignancy before proceeding to people? So I'm asking whether any literature, any recommendations, any guidelines is suggesting this.
Sir, ESFNA is recommended only when there are worrisome features, worrisome features, and the patient has a high risk. Is a high risk candidate for surgery.
Yeah, in this context, I like to also explore the possibility of doing cytogenetics and finding out the various mutations which may be by combination of various tests, we may be able to tell little more accurately the chance of malignancy. And regarding the location, IPMN, is it more common in head, body, or tail? Where it is very common? Can you just enumerate various
More commonly,
location-wise?
more common in the head, sir. Especially main duct type is more common in the head region, and branch duct type can occur anywhere, but more commonly occurs in the uncinate process or tail of the pancreas.
So, what if you have DDs, other pancreatic cysts? So where are they more common? And any gender bias?
Yes, sir. Especially this mucinous or IPMN, they will occur more. IPMN occurs more common, slightly more common in males, whereas mucinous cystic neoplasms occur more common in females. And serous neoplasms will have either equal or slightly male preponderance. Mucinous is again body and tail of the pancreas is more common mucinous, and serous they can occur in. I'm not sure. Mucinous is body and tail of the pancreas. Is more.
I mean, if I say that serous lesions can be completely ignored and observed, do you support my opinion?
Serous, yes, sir, the risk of malignancy with serous, pure serous is very less. So always one can go for surveillance, whether
Srinivas,
unless the
speak in the
patient is
mic.
symptomatic or.
Srinivas, be closer to the
Now,
mic.
is there any selective indication of surgery on serous cyst pancreas?
Symptomatic patient is one indication. Size.
Moderate development.
Without treatment, the IPMN survival is around 40 to 50% is the survival, sir. But with the treatment, again, they say that complications or morbidity can have a survival of up to 30%.
No, other than malignancy, what is the risk? If the risk of malignancy in IPMN is 30%. So if you assume that the remaining 70% should be living, so is there a cause of death other than malignancy in IPMN?
Other than malignancy,
Then at least 70% should be live, because those without malignancy will live longly, and they may get some other complication later on in terms of obstruction. If you do Whipple's, I think a significant patient will die. That is another thing. If even if mortality is 1%, I think 1 out of 100 is going to die.